Thank you for coming along tonight. My name is Michael O'Hearn. I'm a physical therapist with Lakeland. I work at the outpatient physical therapy clinic on Hollywood. I've been there for I've been with Lakeland for almost 25 years, and I've been a physical therapist for 34 years. In my 34 years, I've seen a lot of people with back pain. So tonight, I'm going to share with you some of my experiences as a physical therapist and what I know about back pain as someone who has had back pain. Also, I'll share that with you. I also work part-time at the University of Illinois at Chicago, and one of my research interests actually is in not so much back pain, but in chronic pain, and the two really go hand in hand. So, presentation will be relatively short, but there'll be plenty of time for questions afterwards. All right? So, back pain is common as a cold. I'll get onto that in a moment, but what I want to cover tonight is the fact that back pain is a very, very common condition. Right? I want to dispel a few myths about back pain as well. I want to talk about some physical therapy and exercise options, which the two sort of go hand in hand. And also there are a lot of things that you personally can do to help yourself with your own back pain. Like I said, back pain is very common. It has a point prevalence of just a little over 18%. What that means is that if you met 100 people down the street randomly, 18 of them would have back pain at that time, right? Yes, not just 18% in a year, but find 100 people in church, 18 of them would have back pain as you ask them, do you have back pain? So that's pretty high, isn't it? It accounts for a very high percentage of physician visits. It would depend on what physician practice you're involved with, but it is said that actually outside of the common cold, low back pain is the second most common reason for physician visits. So it's a common reason to go to the doctor. And this is the perplexing thing, it's almost paradoxical. Visits actually to the doctor for low back pain are actually increasing. Right? Back pain's common, been around for a long time, but more people are going to see their physician about it. Before we move along, I want to talk about just general, broad, different types of low back pain. First type, we're going to talk about acute back pain, and as we go through the presentation, I'll bounce from one to the other. Acute back pain is a sort of back pain pretty much everybody in this room would have experienced. That's the pain when you bend over and you go to straighten up, and then you think, my goodness, what have I done? Right? That sort of very, very strong pain that sometimes just lasts a couple of days, and then it's gone. And then sometimes out of the blue, it comes back a year later. Right? We'll talk a little bit about acute back pain. We're also going to talk about chronic back pain. That's the back pain that doesn't go away. All right? Usually chronic back pain is any back pain that's been around pretty much every day for about 3 months. All right? We'll also talk about whether or not there's nerve involvement, right? Because that's an important distinction. Okay, so you can have acute back pain, chronic back pain, add nerve involvement, or take away nerve involvement. All right, so we'll swing back to that as the presentation goes along. Now, like I said, visits for low back pain to the family physician are actually increasing. Look at this graph I got from 1998 to 2010. It's interesting, the blue bars are back pain, the gray bars are back pain and neck pain, and the orange bars are neck pain. Visits for neck pain aren't increasing, but the visits overall for low back pain are increasing. I find that sort of fascinating, really, because technology actually is improved, yet visits are actually increasing. Back pain, if you bundle it into just chronic musculoskeletal problem, it's the biggest chronic condition in the country. I mean, that top bar on the musculoskeletal that says 54%, that includes hip pain, knee pain also, but the majority of that actually would be back pain. So Back pain is a huge problem. If it's such a big problem, if you measure disease in terms of years lived with a disability, okay, back pain actually has the greatest burden worldwide. Right? The World Health Organization measures the impact of disease with what they call a DALY. Okay, a DALY is a disability adjusted life year. Now, one DALY equals 1 year of life lost to either disability and or death. Okay, low back pain has the greatest number of DALYs compared to any other problem. Right, so a good example would be is that you could live to be 75, get very sick with something and die at 77. But you had 75 good years, right? With low back pain, you could come down with low back pain and have chronic low back pain from the age of 40 to the age of 75. And then you've got 35 years of living with a problem, right? Of which you weren't able to work, et cetera, et cetera. So in terms of burden of disease on society, low back pain actually has the greatest of anything, greater than cancer, right? Greater than stroke. Okay, so it has the greatest disease impact. So it's a big problem. This graph here, and this is probably the last of all the graphs. This is from Europe, right? So this is just not a US problem. This looks at Europe, and this looks at the number of DALYs affecting people by region in Europe. Now, I threw this graph in here because it seems like low back pain affects people in Western countries more than others. I don't know. That's a good question. But if you look in this graph here, the purple is Western Europe, and the green is Eastern Europe, and the red is Central Europe. People in Western Europe have lifestyles very similar to that in the US, right? Right. You might need to move to kill your back pain, right? Move to Eastern Europe. So it's not as if the disease is universally spread throughout the world. For some reason, people in the Western countries are more impacted by low back pain than in other countries. That's not to say people in Eastern Europe don't have low back pain. I'm from Australia. The Australian Aborigines, they get low back pain too. But their life isn't impacted the same way it is in the West. Okay. Low back pain is very complicated. Anybody who tells you they have an instant answer for your low back pain is deluding themselves, and probably you, for that matter. Low back pain can be impacted by hereditary factors. Okay, there's certain anatomical things that are passed on that you can blame your parents for that help sort of generate part of your low back pain. Depression is a big part of low back pain, particularly chronic low back pain. Okay, there's a large percentage of people with chronic low back pain also have depression. As a matter of fact, some doctors will treat low back pain, chronic low back pain, remember that's the low back pain that goes for longer than 3 months, with antidepressants, even though the person may not be depressed, right? It sort of comes, so the two sort of somehow are connected, and I can't, scientifically I can't really draw the nice tight connection to make it sort of easy to digest and understand. So depression is linked in. Anxiety is linked into low back pain. People, if they have low back pain and become anxious about their low back pain, or just anxious personalities in general, will have more low back pain. Lack of sleep contributes to low back pain. Stress, obesity, fitness levels, smoking, your education level contributes to chronic low back pain. Individuals that don't have a college education are more likely to develop chronic low back pain, even if you take out the sort of job they're doing, right? In other words, you could have a college-educated individual doing a heavy lifting job and someone who had a high school education doing a heavy lifting job. The individual with the high school education is more likely to develop chronic low back pain than the one that's got the college education. It's complicated. That's what I'm trying to, I don't have an answer for you why that is. All right? It's just very complicated. Work environment contributes to chronic low back pain. All right? Individuals who are unhappy with their job, or particularly unhappy with the way their supervisors treat them, are more likely to develop chronic low back pain and stay that way even though once they get extricated out of that environment. All right? Okay, if we think anatomically speaking, part of the complicated aspect of low back pain is that there are lots and lots of different possible causes. All right, you can think of the intervertebral discs, all right, which are the pads between the vertebrae. They can be causes of low back pain. Okay, we can look at the facet joints, which are the little joints at the back. It's sort of these little hook joints at the back. They can be sources of pain. We could also look at muscles and ligaments. All right, there's the lower part of the back showing the sacroiliac joint, and you can see all the ligaments that wind around the sacroiliac joint. Very easy for any of these things to cause pain. I'm going to give you the big confusing part of the confusing picture in a moment. Muscles can also cause pain, right? So you've got discs, you've got joints, you've got ligaments, and you have muscles, and they can all cause low back pain. So you hurt your back, your number one question is, well, what's causing my pain? Or if you have chronic low back pain, say you've had your back pain for longer than 3 months, that's your question is, what is causing my pain? Don't you really want to know, right? Well, the trouble is many of those different tissues have similar pain patterns. For instance, just because you have pain in your back that goes into your thigh and down your leg, that doesn't mean it's caused from your sciatic nerve being irritated. A pain doctor could inject some irritant into one of those facet joints, for instance, those hook joints at the back, and create the same pain pattern. We could do an injection into your hip and create pain in your leg. I mean, there's papers to prove this. So just because you have pain in your leg and a bit of pain in your back doesn't mean you've got a nerve pinched, right? Because you might, but it doesn't mean you have, because there are similar pain patterns. So it's very difficult to know, particularly in acute low back pain, which tissue is involved, because anybody who's had acute low back pain, and I'm pretty sure that just about everybody in this room has, all right, you have so much pain it's hard to know where the pain is actually coming from. Clinical tests done by a physician, chiropractor, or a physical therapist can be a little helpful, but they're not what they call pathonomic. They're not like guaranteed to know what is actually causing the pain, right? It's a little easier with chronic low back pain to work out what tissue might be driving the pain, because you can have a selective series of injections to eliminate the cause of the pain. But here's the issue, is scientific studies have shown that people that go in and get an injection, say into one of those little facet joints, and get a good amount of their pain relieved, go back 6 months later, get the injection into the same joint for the same pain, no change. That'll happen to 30% of people. Same pain, the same pain that went into their butt and down their hamstring, all right? It was relieved somewhat with the first injection. Go back a few months later for another injection, 30% won't get any relief at all. It's complicated. Right? So you really can't be sure what tissue is driving the pain. And any practitioner that says with 100% certainty is deluding themselves and yourselves. You do get, if there's a nerve involved, that's a different issue, right? Because if you've got acute low back pain and you've got pain radiating down the leg, and you have the doctor or therapist checks your reflexes and then checks the muscle strength around your foot and ankle and your knee and hip. If there's a nerve involved, then you can be a lot more surer than what there is. But if you're just going by pain, you can't be that sure. Okay, And the problem is, everybody wants to really know because the pain is really, really bad. If you're a guy and you get acute low back pain, this is the childbirth pain, you know. For instance, this is the worst pain you've ever had. You will never have pain like a good dose of acute low back pain. I've had it. I couldn't walk to the toilet, all right? I had to get one of my sons to help me up, and I was only 32 years old, right? It was awful, right? And the thing is, it's the worst pain you've had, and if that's the worst pain you've had, you're going to worry about it naturally, aren't you? But if you worry about it too much and you focus too much on what is going on, have I broken something, is something torn, then it's just going to raise the anxiety levels and just make your pain worse, right? And like I said, just because the pain is going into the leg doesn't mean that a nerve is being pinched, okay? Pain can go down the leg for a lot of reasons. All right, so before we get back to, let's sort of take a step back here. You know, I'm not trying to be dismissive. There are some times when you actually have a low back pain, you should really go and see your doctor, all right? And these are some of the reasons. If you've been in an accident and your back pain occurs, so you've been in a car accident or you fell off the bicycle or you fell down some stairs, you should go see your doctor. You might need an x-ray. If you're under the age of 18 or if you're over the age of 50 and you get acute back pain, you probably should go see your doctor. If your back pain is different to your usual back pain, all right? Most of us get used to managing our pain. If we get an onset of pain that's different, we should probably go see our physician. If we get acute back pain and we're taking any steroid medications or immunosuppressant medications, we should probably see your doctor. If you have a history of cancer and you get back pain, you should go to the doctor. If you have unexplained weight loss, and usually it's 10 pounds over a month is the rough guide, but any unexplained weight loss, you should see your doctor if you've got back pain. Actually, you should see your doctor if you have unexplained weight loss regardless of your pain. Okay? If you have any numbness in the saddle area or the sudden onset of bladder or bowel problems, go see your doctor. If you have a loss of sensation or weakness in the legs, it's not due to the pain per se, you should get that checked out. If you have intense night pain, you should go see your doctor. Same goes with fever or chills, or if the fact you just feel sick. I got this back pain and I don't feel well. Go see your doctor. You don't have to suffer at home in silence for that. Okay? But all of those reasons for seeing the doctor actually are very, back pain rarely ever accompanies any of those reasons, except for the age perhaps. Do you know what I'm saying? So most people that get back pain don't have numbness or weakness. They just have pain. All right, so let's go back again. So you've got acute back pain, or you may have chronic low back pain. Your thoughts are, do I need to have an MRI? I really want to know what's going on. Wouldn't it be nice to know what's causing my pain? Well, this is a very interesting study. This came out at the end of 2015 in the American Journal of Neuroradiology. Okay, so this is the journal of the radiologists have. So they've got nothing to gain by publishing this data, by the way. What they found, it's a systematic review. So what a systematic review does is it takes all the different studies and then attempts to pull the information, okay, and then come to a conclusion. So they looked at 33 studies of asymptomatic subjects. So this is an MRI study. So they looked at studies that had taken MRIs of individuals with low back pain that individuals that don't have low back pain, right? So I don't have low back pain at the moment, so I would be a candidate for the study, right? They did an MRI of my back just to see what they could see. Okay, so they're asymptomatic. That's very important to know. The 3,000 people in this study didn't have any back pain. So, what did they find? Well, if you're at the age of 40, you have a 68% chance of disc degeneration. So some of you here are probably a little older than 40. Can't tell. But say you're 60, you have an 88% chance of having disc degeneration. 88%. If you're 70, you've got a 93% chance of disc degeneration. Now, these are people without back pain, right? These aren't people with back pain. These people have no pain. They're just, hey, I'll volunteer for that study. You know, I'll probably get a free coupon to Subway, right? And an MRI, so a good dose of radiation. So, no, and so they're 40-year-olds. I mean, look at the other things. Disc protrusion, 33% of individuals the age of 40. So the point I guess I'm trying to make is that are those bulges in your discs that you saw on MRI because you really wanted to know what was causing the pain, are they any different from the wrinkles in your skin? Right? Is it just another thing that happens as we get older? All right? So I'm not saying that a bulging disc can never cause somebody pain. That's not the point I'm making here. The point I'm making here is that it may not be the cause of your pain because there are a lot of people with bulging discs who don't have any pain. So if you have pain and you think you need an MRI to find out, I really want to know what's going on, right? I need to know what's causing the pain, and the MRI shows you've got a bulging disc. That may not be causing your pain. All right? So you can't hang your hat on your MRI and say, now I know, because really you don't know. And maybe that's why low back pain visits to the doctor are getting more confusing, or more prevalent, is because maybe there was a time where we just said, oh, it's back pain, can't do anything about it, move on, right? Now it's back pain, maybe I should get an MRI. I don't know. Okay, so if you do have something on MRI, are those changes permanent? There was a study in Spine, which is the most prestigious journal for back pain in the world. It's the journal that the spine surgeons get published in. I've never been published in Spine. I wouldn't even submit my work to Spine because I know they would reject it. All right, it's that good. They looked, this paper in 2016 looked at 12 research studies. Right, once again, it was a review where they put all the papers together to see, these studies were follow-ups. People who had MRI, right, showing they got something going on, maybe a disc pinching on a nerve, and then followed up 12 months later. They found that in many cases, now the percentages varied from about 20 to 70%, that there was resolution of the problem. In other words, the disc was no longer impinging upon the nerve, right? The problem sort of cleared up. Right, so those changes, if you do have an MRI, may not be permanent. What may be a problem with your back pain is that some people just have more sensitive pain systems, right? There are some people who experience pain more than others for various reasons, okay? And this is what the functional MRI has shown. That's an MRI that can be done that shows activity in the brain, right? Rather than just something static, you can actually see what's going on in terms of metabolic activity in the brain. And the functional MRI shows that people with chronic pain, they have much more activity in the pain centers of their brain than those that actually don't have chronic pain. And that might be the problem. Their nervous systems are just more active. Whether they're born with it or whether it's acquired, it's not really known. Okay, but what is known is that pain system, or the sensitivity of your pain system, in other words, the threshold of which something goes from just normal sensation to pain, that threshold gets lowered with lots of things. Lack of sleep, increased adipose tissue will drop the threshold, stress, and no exercise. Some real few simple things such as that. Okay, we'll come back to that in a minute. A lot of people think with their chronic low back pain that they need surgery, and maybe they do. So that's really a serious discussion for you to have with your doctor, and it's a very difficult decision to make. So I'm not a doctor, I'm a physical therapist. I don't do surgery, and you don't want me to do surgery because you'd be reading about me in the Herald Palladium, about some whack job that convinced people he was a doctor. That was in the paper the other day, I think. But the thing is, spinal fusion surgery, which by the way is on the rise, actually may not help that much in the long term. This study, and this is a 2016 study, this is a Swedish study, 294 patients. They followed them 13 years after their surgery. Right? So you've got people who were candidates for fusion surgery. Some went to therapy and did their own thing, and then others got the fusion surgery. An average of 13 years later, they went to them and said, guys, how are you doing? And they took some measurements of things. Basically, the people that had the surgery said, oh yeah, I'm better. They were more likely to say I'm better than the group that didn't have the surgery, which is important in itself. But when they measured their medication intake, their activity levels, their employment levels, in other words, how much they were working, there was no difference. So they felt better to a certain extent, but they actually, and their pain levels were no different either. So that gives you an idea of how complicated the problem is, doesn't it? Right, so you've got people saying they're better, but when you measure the things that what we would measure to see if someone was better, there was actually no difference. So that does, I'm not saying don't, have fusion surgery. I'm saying think about it seriously before having fusion surgery, because it may not make that much difference. Now, I do know, obviously I know people who have had fusion surgery and feel great, right? But I'm talking about studies. This is a lot of people in this study. Okay, fusions actually are on the rise too. Despite the fact they may not be as helpful as people would like them to be, they've actually increased a lot. Look at this graph here from the two bars on the left are ages 45 to 64, and on the right, ages 65 and older, going from 2004 to 2014. I mean, that looks like they've more than tripled. This is from Pennsylvania. This is from the state of Pennsylvania, just so it's a limited data set. But I think you could safely extrapolate to the rest of the country to a point. Because another point is the rate of spinal fusion. I didn't put this up here. The rate of spinal fusion varies from what state you're in. In other words, they might do 5 out of 100 spinal fusions in Michigan, but in Indiana they only do 2 out of 100 people. That's what I'm saying. And you'd think if we all had the same sort of back pain, the fusion rate would be equal across the country or very close to it. There are actually fairly significant discrepancies. And I think that in itself tells me that if you're going to have that surgery, and I'm not saying don't have spinal fusion surgery by any means, just think about it very carefully. Okay, so what about drugs, pills, medicines? Well, once again, I don't write prescriptions, right? But I do read. The American College of Physicians actually just came out with a statement saying no drugs for acute low back pain. Nothing. They're not even going to recommend Advil or Tylenol. One study showed that Tylenol was no better than a placebo for back pain, a placebo being the sugar pill. So you got back pain, you take the pill, you're in the study, you don't know whether you got the sugar pill or you've got the active drug, the Tylenol, and no difference. One other study showed that non-steroidal anti-inflammatories gave a very slight advantage over the sugar pill. We're talking half a pain point out of 10. You know, when the doctor or the therapist asks you to rate your pain out of 10, all right? So you got from 8 out of 10 to 7.5 out of 10 taking Advil. That's not a very big difference, is it? That's compared to the placebo. Now, you might think, well, when I hurt my back, I take Tylenol and it helps. Well, don't forget there's a big placebo effect there too, because you're expecting it to help. And I'm not saying don't take it, all right, because that's not my job. I can read, but I can't tell you what to take or what not to take. All right, but actually the Advil may not be helpful. Opioids have actually, the strong pills have been shown to be helpful with acute low back pain, but not with chronic low back pain. And the risks of taking opioids have been well documented in the newspaper recently that I don't have to tell you about it. other than that more people die from opioid overdose than they do in car accidents in Michigan. All right, so I don't want to be like a low back pain nihilist and say there's nothing you can do about it. You know, don't take the drugs, don't do the surgery, don't do this. You can do some things about it. Okay, really, in summary, and I'll go over this a little bit more detail, it depends what stage it is. You treat acute back pain and chronic low back pain a little bit differently, right? For acute low back pain, manual therapies as provided by physical therapists, osteopaths, or chiropractors actually have shown to be better than nothing, right? For acute back pain, that's the pain you got when you just suddenly strained at something. The best treatment for chronic low back pain, and some researchers actually describe it as a magic bullet, the best treatment is exercise. Okay, so I've got to put in a plug for physical therapy because that's what I do, right? So what do physical therapists do? They do manual therapy and exercise for back pain. Now the manual therapy, which like I said works best for acute low back pain, all right, not so much for chronic low back pain, is used by PTs, chiropractors, DOs, MDs. It's not an exclusive set of skills to any one profession, despite what some professions may say. Okay. Manual therapy could include joint mobilization or manipulation, and I'll explain the difference in a minute, muscle energy techniques, and any sort of massage type techniques. All right, now here's a myth about acute low back pain. It's the feeling that you've put something out of place. Even if your back looks like this, and I've seen a lot of backs that look like this, you're pretty sure that something is out of place, right? And I need to have it put back in. So I need to see the PT or see the chiropractor get things put back in. Even though your posture is off, discs don't slip in and out of place. They just don't do it. They feel like they do it. Honestly, they do, but they don't. What's going on is you've got a lot of pain and you have a lot of muscle tension. And even if you look like you walk into the chiropractor's office or the PT clinic, you look like this, and you walk out straight and normal, that doesn't mean that something was put back in, right? It means the treatment was successful and I'm happy for you, but it doesn't justify or validate the theory or the concept or the construct that something popped out and needs to be popped back in, all right? Because that doesn't happen. And I don't like it when some PTs and others make their patients feel they're dependent on us to put things back in when they come out, right? Because it doesn't work like that. That person has a lot of pain. So, things that are helpful for that sort of acute type of back pain is mobilization, where it's a passive motion where the therapist or the chiropractor or the osteopath or the physician stretches the joints up to how much end of range. You know, how much movement you've got, they'll oscillate into that, give you some passive movement, and they'll oscillate and move it a little bit, whereas a manipulation is they'll take you up to the end of the amount of movement you've got and give you a big old whack, all right? And both seem to be pretty much equally successful. The manipulation can give very quick results, but mobilization can do the same, just takes a little bit longer. So like I said, the research says that mobilization and manipulation for low back pain is somewhat helpful for acute back pain. It's not the magic bullet, right? But most people get some benefit from it, more so than taking medication. And it's not seen in the research to be helpful for chronic back pain. That's not to say it won't help you a little bit. I'm just talking about what the research says, okay? It doesn't help most people. Muscle energy techniques are techniques developed by osteopaths, used a lot by doctors in this area because a lot of them actually originated from Michigan State. A muscle energy technique uses muscle contractions to relieve pain and improve motion, all right? It doesn't have the good and evidence to support its use that mobilization and manipulation has, but it might be helpful for you. Massage actually is helpful right, as a standalone treatment, but it doesn't actually stand out compared to mobilization or manipulation, right? It might be what you like and your back it's good for your back, but it may not be the thing that actually helps you the most. All right? So I'm not saying don't do it. I'm saying it's helpful, but it's not when it's compared to another active treatment. It's helpful if it's compared to nothing in the research, or just go home and lay down for a couple of days. Okay, so physical therapists and others use exercise for low back pain. Now, the sort of exercise that you get is you'll get what they call specific exercises, and I'll talk about the difference in a minute, and there's very general exercises. Now, here's another myth. The thought, when we're talking about exercise, we're thinking that your back is weak. All right? Your back is not weak. All right? Not inherently anyway. It might be weak because you don't use it. You don't do enough exercise. But you weren't born with a weak back. Though I can't testify, the man on the bottom there, you know. I don't know what his back's going to feel like the morning after this. Right. But actually, backs are inherent, and that's a problem that we have. It's a mindset that we have when we get back pain. I've got a weak back. I shouldn't do anything. And then if you don't do anything because you've got a weak back, I shouldn't do this, do whatever, is that your back actually does become weak through disuse. Right? Okay, your back is actually a lot stronger than you think. All right? It was designed to help you lift things. Right? There is not a flaw in your body. Right? Your back is stronger than what you think. Okay, here's another myth before we talk about exercise. That a strong core will actually cure your low back pain, right? That if you keep exercising and exercising and exercising, your back pain will go away. No, that's not the case. This is the tricky part with low back pain. This has sort of come out in the rehabilitation research in the last few years. Is some people, their back and hip muscles are overactive, and some people, their back and hip muscles are underactive. Right? And that's, as therapists, that's what we sort of try to tailor the exercise routine to whether you're overactive or underactive. The overactive people are the ones that stand very rigidly and they look at the thing they dropped on the floor and they think, how am I going to get down there? Because their muscles are just always contracting and just locked up. Giving those people strengthening exercises doesn't really help. What they need is things to dampen down, bring down the tone of their back muscles. And some people, they have underactive back muscles. They just don't do enough. Most people probably fall into that second category. Okay, so our backs are strong, right? But keep on doing strengthening exercises may not be what you need. Now we're coming back to talking about specific exercises, right? Two types of exercise, specific and general. Specific exercises is something that therapists and other people do. These are called directional preference exercises. In other words, what they do in this exercise is if you've got back pain, the therapist will try to find a movement that you can do to relieve the pain, hence directional preference. In other words, they'll look at movements. If I bend backwards 10 times, does that actually relieve the pain that's in my butt? Or if I bend forwards 10 times, do I get relief of pain in my butt or in my leg? And that movement becomes your directional preference, and that's something that you can do at home. Right? Like I said, it goes in different directions, and they talk about centralizing the pain. In other words, if you bend forwards or you bend backwards and you've got pain in your leg, does the pain move up? I mean, the pain in my back is still there, but I've got less pain in my leg. It becomes more central. Okay, like I said, move the pain proximally. And the most common movement used actually is bending backwards. Okay, and like I said, that can form the basis of a home exercise program. And sometimes these are called McKenzie exercises. Some of you may have actually seen. Some doctors actually will write McKenzie exercises on the prescription. And that's what they mean, is exercises designed to find a movement that relieves the pain. So that's an example of a specific exercise that a therapist might do. Another type of specific exercise the therapist might do is what they call motor control. All right, that's a funny name, isn't it? But it's an exercise designed to help activate the deep trunk muscles. Because some research has shown is that some people with back pain, they've got all the wrong muscles are all tightening up, you know? All their lower back muscles are in spasm, but the deeper muscles that help control the trunk, they're actually not contracting properly. So if you get the deeper muscles to contract through a series of exercises, the superficial muscles that are in spasm will relax. All right, so these exercises don't cause any pain. They're low load, they're pain-free, and they're usually done comfortable position laying down. And then they progress to standing. Now these exercises might be best, and there is some research that we've done to show they might be best for the overactive trunk muscles. You know what I said? Some people got too much activity in their trunk muscles, and some people have too little activity. These exercises might be best for those sort of people. And there is significant evidence that it's better than nothing if you've got chronic low back pain for these exercises. But for the acute low back person, it's probably not that helpful, right? So these motor control exercises might be beneficial for chronic back pain. One study actually showed that it decreased the recurrence rate of low back pain quite significantly. If you're a young person, say you're in your 30s and you hurt your back for the first time, you've got almost an 80% chance of re-injuring it within 12 months. This exercise program reduced that injury rate from 80 to 35%, which I think is pretty impressive. You know, when you look at time lost from work with back pain, it's pretty good. Okay, so there are your two types of specific exercise. The directional preference, the movement to decrease the pain, and the motor control exercise to help contract the right muscles. Cardiovascular exercises would be in the general exercise category, and biking, walking, water activities are included, and all these things help back pain, right? People report less back pain who are more active. And most people don't meet the American College of Sports Medicine's recommendation of 150 minutes of moderate intensity exercise per week. That's not like a dawdle, that's just a nice brisk walk for 150 minutes, so that's a couple of hours there, 2.5 hours, right? Right now, cardiovascular exercises have been proven in study after study after study after study to decrease pain. What they do is that you go into the study and they'll jab you with needles and things and rate your pain, and then they'll get you walking, and then they'll jab you with needles again and you rate your pain as less, all right? Yeah, otherwise they'll jab you again. Also, it improves mood, right? People who exercise regularly, now this is the challenge of living in Michigan except for the last week, right? You know, when I moved here from Australia 25 years ago, I moved here in my first November, there was officially 3 hours of sunlight in the entire month. I was looking at Qantas flights, see, I've got to get out of here. It improves mood, particularly outside. So walking on a treadmill is good for exercise, right? Or if riding the stationary bike. But if you can get outdoors, you will actually even get a bigger effect, right? Because your mood will be improved and that pain won't seem as bad. Okay, people who exercise use less pain-relieving medication. So cardiovascular exercise, strengthening the trunk and the hips for those people who have the underactive back muscles seems to be the most effective thing. Most health clubs have machines like this, right? And they work wonders on some people. But look at the abdominals, the hips, the lumbar spine, okay, because studies have shown that people with low back pain generally have weakness in these areas, okay? So you may feel like you have a weak back, that's true, but your back was designed to be stronger than what it is, right? Does that make sense? Okay, general strengthening has been shown to be beneficial in chronic back pain. Like I said, may be best for those underactive muscles. So here's another myth. Well, I've tried exercising, but my back gets sore, right? Aren't I making my problem worse? Well, think of it this way. This is very important. Pain with exercise does not necessarily mean you have tissue damage. That's a common misconception. The fact that we feel pain and therefore we should stop exercising because I'm damaging something. Okay, that doesn't mean anything. I mean, it has some meaning, but I think what we do is we over-attach the meaning. Do you know what I'm saying? In other words, we give it too much value, the fact that we're feeling pain while we're exercising. Some people have sensitive pain systems, and the irony here is that lack of exercise will make your pain system more sensitive. And then when you go to exercise, you feel pain, and then you're like, you're not going to exercise as much. When you feel pain, you think, is it good pain or bad pain? Now, see, that's a good question, isn't it? Because good pain is that pain you might get with you're walking up a hill and your legs start to cramp a little bit because the muscles are working hard. That's good pain because you know long term it's going to be beneficial. Or that soreness you get after you've worked in the yard, right? That's good pain. Bad pain, it's that sharp, piercing, deep joint sort of pain. That's the sort of pain you should, look at. And some people, if you've got a sensitive pain system, you can't tell the difference because all the alarms go off when you get pain, right? You need to go back a step and think, okay, is this good pain or is this bad pain? If I had this pain before, then what happened, right? Is it just muscle pain? How long does it last? I've had this before, it went away. We have to, sometimes people will overestimate the threat value of the pain they're feeling, okay? And that's part of the problem in Western society, I think, and this is just not me who thinks that, is that we are overinflating the threat value of the pains, the aches and pains that we feel in daily life. We're running off to the doctor, we're demanding an MRI, we're demanding we get medications because we want to live pain-free. Okay? Now, the baby boomers are the worst at this. Study after study has shown the baby boomers don't tolerate pain. All right? The generation, they've compared the generation ahead of them to the baby boomers, So they'll do a study and then 20 years later they'll test the next generation. Baby boomer generations are significantly more likely to be alcohol and drug dependent and have difficulty getting out of a chair and walking up one flight of stairs, right? So that's it. So I think that's a generational thing. Now, I can't speak for Generation X or the millennials, okay, but I do know because I'm a baby boomer. Okay, if you do have pain while you're exercising, you're moving around, are you doing more, right? There's more to it than just having pain. Okay, what are some other things you can do? You could lose weight, improve the quality of your sleep, stop worrying about your back, and stop smoking, right? Lose weight. Now, this is interesting. Not only does increased belly fat make your back muscles work so much harder than what they should be, but fat, particularly visceral fat, throws off a chemical, a cytokine, that actually stimulates nerve endings. So people who are carrying too much adipose tissue actually will feel more pain than people who don't, right? Just from having the presence of the fat. Okay, and now that goes for tendon injuries as well, right? But it also goes for back pain. So it's not just a matter of, well, if I lose 10 pounds, I'll get that 10 pounds will be 10 pounds off my back or 30 pounds off my back or whatever the calculation often is. There's a chemical secreted by fat that sensitizes tissues. You need to improve the quality of your sleep. Anybody who's getting less than 6 hours of sleep a night is at risk of maintaining chronic pain. Now, of course, it's a circular argument that you say, well, I'm not sleeping because I'm in pain. Well, that's where you can work with your physician to actually improve the quality of sleep. That might be the number one thing you need to do to actually reduce your pain, is actually to sleep better. All right, so 7.5 to 8 hours. Anybody less than 6 is definitely at risk. Stop worrying about it. Stop thinking my back is degenerated. Right? That MRI hasn't really helped. Right? I know people who have back pain who refuse to get an MRI because they don't want to see the results. right? As long as I don't have cancer, I'm good, right? Stop thinking bone on bone. If you use these constructs to think about your problem, you're not going to move on too much, are you? All right, think your back is strong. Think that it does come down to, now not every back problem is going to be cured with attitude, but you can help it with attitude. Think exercise increases blood flow, which helps injury to heal. So you need to self-challenge the pre-existing belief you may have that crappy-looking MRI actually is the cause of all your pain. Because there are a lot of people who have that same MRI that you do that don't have any pain. Well, like I've said, I'm not saying that's not part of your problem, but I am saying it's possible that it's not. Well, this speaks for itself. Smoking really, I know one neurosurgeon that said he never had to operate on a back for a disc herniation of a non-smoker, right? There's something about circulation and disc health and back health and overall health. I mean, I don't need to argue that. Okay. Well, that's about, got time for questions now. You got questions? There's a microphone circling around.
How do you remove your back pain? What did you do?
What do you do?
What did you do? You had
Oh,
back pain.
actually I took some Advil. But that was like 20-something years ago. If I'd had that study, I don't know. I may have still taken Advil. I just moved. I actually didn't do anything for a couple of days, and then it went away. But I kept moving. I had 4 young kids. I was at Disneyland, and I wasn't going to keep them in the hotel room with me while so I just sucked it up, pretty much. All right.
Any thoughts on a mattress, firm, soft, styrofoam?
The question was thoughts on a mattress. The best mattress is the one that feels best for you. Probably knew I was going to say that, didn't you? There's no research I'm aware of, and I'm pretty sure there is none, that shows that if you've got this back pain, you should sleep on this mattress. Just like people who used to sleep on water beds in the 80s thought that was the greatest thing for their back. Nobody has water beds anymore, do they? And then probably in the 90s they slept on the floor, I don't know. But whatever mattress makes your back feel the best is the best one for you. It's like a shoe. You know, you wouldn't, if you said, what sort of shoes should I wear to work? Well, what feels the most comfortable? So that's why those beds that have the adjustable are helpful, than just the inflation.
You mentioned earlier that steroid use could aggravate back pain. Does that include an inhaled steroid?
Yes, it does.
For asthma?
My point there was if you're taking steroids and you have an acute back pain, you may have a fracture. That's why you should go to the doctor. And it does include inhalants too. So that's not saying you do have a fracture, but that's a red flag is what we call them. Hang on. I'm going to go. We got a microphone going around, but I'll be here afterwards.
I just wondered if your back pain is because your spine is compressing. Would that inversion kind of a contraction help back pain?
You'd think it would, and some people it does, and some people it doesn't. That's just all part of the complicated problem is that if you have back pain, you meet 5 people, they've all had back pain, they'll give you 5 different things that they did for their back pain, and then they will swear by it. And you will try 1 or 2 of them, you think, well, that's rubbish, that doesn't work for me. But you would think, mechanically speaking, that would be helpful. And therapists do have traction units, right? But even when you've got a compressed nerve, you would think hooking somebody up to the traction would just what you need. Nope, the research doesn't support that either.
What about, like I was given a belt or a brace to wear around my waist for lower back pain?
What they've shown with belts actually is 2 things. One is that people get rid of them after a few months because they stop working. And 2 is that they tend to have an immediate effect on some people, particularly if you've got that underactive muscles. They actually help your muscles contract a little bit better. But then your body sort of gets used to it and it stops working.
That's what I wondered, if that made your muscles rely on the belt rather than your muscles.
Kinda. It doesn't make you get weaker. What it does is it made your muscles work harder at first and gave you some relief. But then what happens is it stops working. And if you've got that overactive type of back muscles, sometimes it makes it worse.
You see a lot of advertising about laser surgery.
Yeah.
Is it any different than having some?
You know, I've seen the ads, and I don't know. I'm skeptical of anything that shows people in doing this and all of a sudden walking out and walking their dog again, you know, after, and a little Band-Aid. I am skeptical. I'm not aware of any research. I try to follow the therapy research as much as possible. You know, I've been around long enough to know with back procedures, there is things that a few years ago, they did this procedure for back pain from degenerated discs where they put this little catheter in and they cooked the disc. They fried it, right? To make it stiffer and to stop it from being all wobbly to treat people's pain, and they would burn some nerves at the same time. It had this fantastic, this is in the 90s, it had this fantastic 80% success rate in this case series that came out, you know, where they look at 50 people that had it, and they were about 80% better, you know, 80% of them are 80% better, which is pretty good. A few years later, they did a double-blinded randomized controlled trial where not even the surgeon knew what he was doing, right? Right? Some people, they'd put the thing in, they didn't even turn it on, you know, but the surgeon didn't know that because it was blinded and the patient didn't know it. The only person who knew was the technician who was operating it. They found there was no difference in people who got their discs cooked and those that didn't. And there's study after study with surgery in orthopedics that shows that. Not for all orthopedic surgery. You know, the hip replacement is a fantastic surgery, for instance. But some of these new surgeries that come along, you just got to be, just wait, you know. For some reason, people have fantastic results early on. And I'm not saying the studies are fabricated or anything. I'm just saying as we as people, we go in with expectations, right? Just like in that spinal fusion study. Those people thought they were better and said they were better, but they weren't doing anything, you know. So were they better? I'll go over here, yep.
Do you know of any studies that have been done with chronic back pain and heat treatments, like sleeping on heat pads, or like heated mattress pads, or saunas, or hot tubs?
No. But once again, I know lots of people that have done all the sort of things that you say and feel fantastic. And if I can only go on the research. So if I have a patient that tells me that they sleep on a hot pad and makes their back feel great, I say, fantastic. Right. You're not doing any harm. But do I say you should go have a sauna and treat your low back pain as a first line of therapeutic intervention? No. I personally try to see, okay, are you an over muscle user or an under muscle user, and then get you moving that way. Or are you acute back pain, and then we'll try some manual techniques or specific exercises to bring your pain down, and then move on from there.
Okay, 20 years ago, I successfully dropped a three-pack a day habit by the use of acupuncture. Do you think there's any benefit for chronic back pain through acupuncture?
I think so, but I don't. I'm not practicing acupuncture. I don't, I'm not up to date, but from what I do know, I think so, you know what I mean, for some people. So yes, I think it is something that people could consider that have chronic back pain is acupuncture. But I don't do it, you know. But I know there are some studies that show it's helpful. And that's part of the problem, is that you helped, acupuncture helped you, but someone else might go with chronic back pain and say, this didn't do a thing. What helped me is I did yoga. I took up a Pilates class. Right? And then other people take Pilates and it's the worst thing that ever happened to them. Right?
All right, we have time for one more question.
Yep.
I believe Michael will stay around if you guys want to come up after.
Yes.
And don't forget to fill out the evaluation forms that were in your bag. It's a white sheet. You just leave on the table and we'll come around.
Degenerative disc disease in your upper back, like in your neck or in your thoracic spine?
Just in my back, not neck particularly, above the lower back.
I would take the same approach for the lower back. One is it you've had the studies that show you've got the degenerative disc.
I haven't had the studies, but I've talked to others who have, that the pain goes around in various places.
Right.
And that's exactly what mine does.
Well, I would just, in extrapolating this, perhaps that is not causing the pain. Perhaps it is the muscles. Perhaps the muscles need to be strengthened. Perhaps the small joints around the back are stiff and they need to be some exercises to loosen them up. So there are a lot of different things that could be done, but I'm not going to say specifically without having someone evaluate you.
What's the difference between chiropractor and the physical?
Difference between chiropractic and physical therapy. That's a very good question. I actually studied chiropractic for 2 years in Sydney, so I feel somewhat qualified to answer that question. Chiropractors, it depends on the philosophy that the chiropractor has, right? But they believe that a lot of our problems are the result of a spine that's out of alignment, and that adjustments to the spine actually put you back in alignment and create good health. Right? Now, some chiropractors just concentrate on the neck and think that if you just treat the neck, it treats everything else. Chiropractors around in this Michigan area are generally pretty good. I've got no real complaints. I mean, I'm not, they tend to use a little bit more manipulation rather than mobilization, right? That would be the one difference. Some of their treatment tables are a bit different. They do some exercise, but not as much as you would get in a physical therapy clinic. So that would be the difference. There's a lot of overlap. Most of the research in spinal manipulation actually is done by physical therapists, funny enough. Okay, I think we're just past 7 o'clock, so thanks for coming along.